Okay, so we can start. In today's session, I'll be taking two subjects only, orthopedics and ENT, right? So because previously I was trying to include many, but then I thought that it will become a very lengthy session, and already we are little late for the night, right? So I'm just taking two subjects in today's session, orthopedics and ENT. Now, the very first question was about the Gartland staging for the supracondylar humerus fracture, which was shown in the X-ray. Now, if you look here, here you can see this is the posterior aspect, right? So this is the posterior aspect, and this is the anterior aspect, something like this. Okay, so this is the anterior aspect, right? So what we can see here, that the fracture is something like this, okay, something like this. So there is a posterior hinge and there is opening on the anterior side. So whenever we have this kind of configuration in supracondylar fracture, this is known as Gartland type 2, right? So it means there is contact at the posterior cortex. This is the posterior cortex and this is the anterior cortex. Clear? So there is some contact in the posterior cortex, but the anterior cortex, anterior cortex is slightly separated out, and that is what the Gartland type 2 is. So on the posterior side there is a hinge. Now this is Gartland type 2. Suppose if we have a fracture, suppose if this is the fracture, right, where we can see the two bony parts undisplaced. So there is no displacement at all, although we can clearly see a fracture line here. So this is the Gartland type 1, right? So in Gartland type 1 there is fracture line but without any displacement of the fracture fragments. In Gartland type 2 we can see a clear-cut displacement but only involving the anterior cortex. There is a hinge at the posterior cortex. Now if both the fragments are clearly separated and you can say there is displacement, right, this becomes Gartland type 3, right? So this is Gartland type 3. And when there is multi-directional instability, that becomes Gartland type 4. So this is Gartland type 4, right? So it is quite easy to identify the first, second and third on a given X-ray, right? So if this is the X-ray which was given in the exam, then this is Gartland type 2, right? So we can see anterior opening and posteriorly there is a hinge, right? So there is a hinge posteriorly. So this is Gartland type 2 supracondylar fracture, okay? So this is how, and if we can just take it with the help of an image, in type 1 there is no displacement at all. So with the red line we can see the fracture line, right? So if we look it clearly, so here we can see a clear-cut fracture line, but this is the proximal and this is the distal. So the posterior, the proximal and the distal fragments, they haven't displaced at all. So this is type 1. Now in type 2 we can see an angulated and there is a posterior hinge. So intact posterior hinge. Now here you can see this is the hinge, or what we'll say intact posterior cortex, and there is opening on the anterior cortex. So this is the anterior cortex, right? So this is type 2. In type 3 you can see there is complete displacement. So this is the proximal fragment and this is the distal fragment, and we can see that both the fragments are separated from each other, right? So that is type 3. And in type 4, this is multidirectional instability, right? So here we find multidirectional instability, right? So the fragment, they can move anywhere, and there is complete parosteal disruption. Okay, so either it can go posteriorly, either it can come anteriorly. Okay, so this is the Gartland classification for supracondylar fracture. Okay, and the usual one which is asked in the exam is either type 2 or the Gartland type 2 or Gartland type 3. In type 2, we can see a posterior hinge. The anterior one, it just opens up, whereas in type 3, there is no contact between the proximal and the distal fragment. Okay, so I think it's quite easy to remember. Now there was another question, and it was about the cochlear implant component, which was discussed on a X-ray, right? So this was the X-ray given, and this is actually an transverse view. Okay, and this shows the placement of the cochlear implant, right? Now here the question was about that what portion of the implant is this. So if you can see here, this portion is slightly curved like this, and this looks something like the cochlear turns, right? So this is actually the electrode of the cochlear implant, right? So to understand this particular image, we have to firstly understand that how does a cochlear implant actually looks. So this is a picture of a cochlear implant. So it has certain portions. Now one is speech processor, then there is a transmitter, just opposite to that there is a receiver, and inside the cochlea, if you see, this is going inside the cochlea, right? So this is the electrode of the cochlear implant, right? So this is the electrode. Clear? So this is within the cochlea, right? So if you see it on the X-ray as such, again you can see a curved assembly here. So this is the electrode, right? So it is just curved something like this. Then there are the receiver, transmitter, and the speech processor. Okay, so this is the basic arrangement of the cochlear implant, and the electrode is placed within the cochlea. So that is very important for you to remember. So the electrode is placed within the cochlear turns, and therefore you will see slightly curved configuration here. So this is a cochlear implant, and this is the electrode of that cochlear implant. And other parts include the speech processor, transmitter, receiver, and of course the electrodes. So these are the few parts of the cochlear implant, right? So you can see this is the skull, right? So receiver inside, the transmitter outside. Okay, so this is the electrodes of cochlear implant, right? Okay, next question. Now the investigation of choice for juvenile nasopharyngeal angiofibroma, and I think this is such a important topic. In every exam we have a question from this topic, right? So in every exam we have a question from this topic: juvenile nasopharyngeal angiofibroma, investigation of choice. So if you see, this is a contrast enhanced CT scan. Clear? So this is the investigation of choice for juvenile nasopharyngeal angiofibroma. So contrast enhanced CT scan, right? So this is the investigation of choice. Now I think most of you must be knowing that in juvenile nasopharyngeal angiofibroma we never do biopsy. So biopsy is contraindicated. Why? Because this is a benign vascular tumor, right? So it is a vascular tumor. If you try to do biopsy, it will start bleeding. So don't go for biopsy. So biopsy is always contraindicated. And what we do a contrast enhanced CT scan. And yes, what we will see here, now we will see a classical Hallman-Miller sign. So we'll see a classical Hallman-Miller sign, and let us see how it looks like. Now this is the maxillary sinus. Okay, so this is the maxillary sinus. Now this is normal side. Okay, this is normal, and this is the tumor here. Now look at the posterior wall of the maxillary sinus. So this is the posterior wall, right? So this is the posterior wall. Clear? So you can appreciate that it is bent backward, right? Or you can say that there is convexity backward. Now look at the posterior wall of the maxillary sinus on the affected side. Now here we can see that the posterior wall, it seems, has been pushed forward. Okay, so it has been pushed forward by the tumor. Clear? And therefore it creates a concavity towards the tumor side. So this is the difference, and this is what is the explanation for Hallman-Miller sign. Got it? So contrast enhanced CT scan, never do biopsy, Hallman-Miller sign, where the posterior wall of the maxillary sinus is pushed forward and therefore it appears concave towards the tumor. So this is the summary for the imaging method for juvenile nasopharyngeal angiofibroma. Now there was another image in which the students were supposed to identify the blocked structure, which was marked with white arrow. So this was a coronal CT scan, right? So this is a coronal CT scan, and the arrow was here. Okay, so this is the point where the arrow was marked. Now the students were supposed to identify which part is blocked anatomically. Now to understand or to answer such kind of questions, you have to understand the anatomy of the region first. Okay, so this is of course a coronal section, and this is orbit, this is the maxillary sinus. Okay, this is maxillary sinus, and now you have to think of the anatomy of the lateral wall of the nose. We know that in lateral wall of the nose there are meatus like superior meatus, middle meatus, inferior meatus. Then there are some bony projections which are known as turbinates, right? So here we will mark out the turbinates first. On the lower side is the inferior turbinate. Okay, so this is inferior turbinate, and as you go above, then you will find middle turbinate. Okay, so middle turbinate, which is slightly distorted on this side, right? So middle turbinate. Okay, now we know that below the middle turbinate there is middle meatus, and in the middle meatus there is opening of the maxillary sinus. So the maxillary sinus opening is something like this in the middle meatus. Okay, so this is the opening of maxillary sinus. Okay, and you must have heard of hiatus semilunaris. So this area is hiatus semilunaris. Okay, so this is in short about the anatomy when we take a lateral when we study the lateral wall of the nose structures on a coronal plane. Now I have taken few images just to simplify the things. So we are discussing the structures of the left side. So firstly I'll draw the I think middle this maxillary sinus is clear to all. So this is the maxillary sinus. Okay, now this one is the inferior turbinate. Okay, so this one is the inferior turbinate. Then above that we have the middle turbinate. So this is the middle turbinate, which extends somewhat like this. So this is the middle turbinate. This is the middle turbinate, and this is the inferior turbinate. Okay, then this is the opening of the maxillary sinus. Okay, and it is coming into the middle meatus, right? So this is the course of the opening of maxillary sinus, and this all area is known as the osteomeatal complex, right? So this, which is circled in dotted circle, that is all osteomeatal complex. Now osteo means the bones and meatus is related to the middle meatus here. So that is osteomeatal complex. Okay, and the hiatus semilunaris, just above that we saw one more projection that is known as bulla ethmoidalis, right? So this is the bulla ethmoidalis, which is lying above the hiatus semilunaris. Okay, so this is the basic assembly in relation to the opening of the maxillary sinus. Now if we correlate it with the coronal CT scan, so firstly I think maxillary sinus is clear to all. So this is the outline of maxillary sinus, okay, in the maxillary bone. So this is the outline of the maxillary sinus, right? So this is the maxillary sinus. Then this is the inferior turbinate. This one is the inferior turbinate. Okay, and this one is the middle turbinate. Okay, and this is the opening of maxillary sinus, and it is coming into the middle meatus, something like this. Okay, so this is the course of this is the path of aeration of maxillary sinus through the hiatus semilunaris, and just above the hiatus semilunaris we have a prominence that is known as bulla ethmoidalis. Okay, so this is the course of the maxillary sinus, and this all area is known as the osteomeatal complex. Okay, so this all area is known as the osteomeatal complex. So this is osteomeatal complex, right? So in this case you can say there is a blockage of the osteomeatal complex, you can say, right? So you can say there is blockage of the osteomeatal complex, or in simpler words you can say there is blockage of the maxillary sinus opening, right? So either of the words are true for this particular thing, because what we can see here, that there is no opening for the maxillary sinus. So you can say that there is blockage of the maxillary sinus, or you can also say that there is blockage of the osteomeatal complex, which is actually related to the opening of maxillary sinus, right? So this was an image, and the answer has to be either osteomeatal complex or maxillary sinus opening. Okay, so this is how you should remember the anatomy of the coronal section with respect to the lateral wall of the nose. So this is very important here. Chalo. Now there was an X-ray of the lumbar spine lateral view, and here we can see that there is a fracture line which is running something like this. Okay, right? And we can also see a bony chip anteriorly. So such kind of fractures are known as chance fracture, right? So this is chance fracture, also known as seat belt injury, right? So this is chance fracture, also known as seat belt injury. And what you can see here, there is compression on the anterior side and there is distraction on the posterior side, or towards the posterior element, right? So we can see that the posterior elements are moving up away, whereas the anterior segment or the anterior part of the vertebra, it is coming closer. And one more thing, if you look at the vertebra above, see, this is the outline of the vertebra above. Similarly, you can see the outline of the vertebra below, right? But if you see the outline of this particular vertebra, you can see that on the anterior part, the dimensions are less as compared to the dimension on the posterior part, right? Whereas if you look here, it is almost same, right? So here also the dimensions are almost same. So it shows that anteriorly there is compression and posteriorly there is distraction. So this is, if someone asks about the mechanism of injury, anteriorly there is flexion, or you can say compression, right? And posteriorly there is distraction, right? And this explains the mechanism of injury, in fact. So flexion, distraction, injury, right? So if someone asks you about the mechanism of injury, so the mechanism of injury becomes the flexion, distraction, right? So that is the answer if someone asks you about the mechanism of injury for this particular kind of fracture. So this is flexion, distraction, injury. Clear? So anteriorly there is flexion or compression, posteriorly there is distraction, or means the parts of the vertebrae, they are moving away, right? So this is the mechanism here. Anteriorly you can see there is compression, and posteriorly you can see that the fragments are moving apart, so that is distraction. And this is the usual mechanism. Anteriorly again you can see there is compression force, and posteriorly there is distraction force, right? So this is the chance fracture, or also known as seat belt injury, right? So this was one question in the exam. Then we move to next question, and this was about best staining method whenever we want to do a biopsy for laryngeal carcinoma. So for this you can just remember that this is hemotoxylin and eosin stain, right? So for best stain for this is hemotoxylin and eosin stain, right? So that is what we do for majority of the tumors or carcinoma. And as far as the histology of laryngeal carcinoma is concerned, you can see that you will find all the features of malignancy, that is mitosis, irregular nuclear outlines, or prominent nucleoli. So these are all malignancy features, right? And here we can see that the tumor is extending within the cricoid cartilage, so it is an advancing tumor here, right? So this is what is hemotoxylin stain for laryngeal carcinoma. Chalo. Next question was slightly tricky question, and here a patient presented with swelling in the leg and X-ray showed Codman's triangle, but there was an important clue that this tumor mimics osteomyelitis. Now what does this mean? That there is Codman's triangle and the tumor is confused with osteomyelitis. Now when we say Codman's triangle, it is actually a kind of periosteal reaction, and most of the students, the moment they hear the word Codman's triangle, they think of osteosarcoma. Yes, it is also seen in osteosarcoma, but it is not specific to osteosarcoma, right? So it can be seen in osteosarcoma, but it is not specific, right? So it is not specific for osteosarcoma. And when I say it is not specific for osteosarcoma, it means it can be seen in any other condition where there is periosteal reaction. So this Codman triangle is actually representing periosteal reaction, right? So this is one thing, that the condition is having periosteal reaction. Now the condition is looking like osteomyelitis. So it means in terms of age group, which is second decade, right? Then in terms of location, which is around the knee joint, right? Then in terms of presentation, the presentation can be, pain, swelling, fever, right? So the two conditions, like the condition, स्वतंत्र कुमार, यस, मैं उसका भी करूँगा, पेपर 2 का भी करूँगा, ठीक है? जैसे जैसे मेरे को क्वेश्चंस मिलते जाएंगे मैं सेशंस लेते जाऊँगा, राइट? तो थोड़ा सा हम 3-4 दिन के करीब हमको सेशंस रखने पड़ेंगे, तभी हम मेजॉरिटी ऑफ द क्वेश्चंस डिस्कस कर पाएंगे, राइट? मैं करूँगा, जितने मिलते जाएंगे मेरे को मैं करूँगा पक्का, ठीक है? डोंट वरी. So the point which I've mentioned here, it is actually in terms of osteomyelitis and the condition which is given in the in this particular question. So both the conditions, they are seen in second decade, they are commonly seen around the knee joint, and they present as pain, swelling and fever. Now when we go to the X-ray, now this is of course tibia and this is fibula, right? And what important, you can see the growth plate, right? That confirms that this is a case, is a X-ray of a child who hadn't attained maturity yet. Now what we can see here, there is involvement of the diaphysis, right? So you can see this is all diaphysis, number one. And then secondly, you can see that there is slight upliftment of the periosteum, right? So you can see this is somewhat Codman's triangle. So this is the Codman's triangle here. Similarly, you can see on the other side, right? If you draw the outline something like this, you can see this is the Codman's triangle, okay? So Codman's triangle. Now when we discuss osteosarcoma, we always discuss Codman's triangle in metaphysis, but here the part of bone involved is diaphysis. So when we take all these words together, diaphyseal involvement in a child second decade, right? And the condition which mimics osteomyelitis, the answer comes out to be Ewing's sarcoma. Clear? So the answer for this particular question is Ewing's sarcoma and not osteosarcoma, because the point which goes against the possibility of osteosarcoma is of course the location of the tumor, which is diaphysis here. Clear? So that is how, just because of this simple thing, the answer has changed. Would have it been in metaphysis, obviously I would have gone for osteosarcoma, but this is a diaphyseal entity which is in differential diagnosis of osteomyelitis. This is Ewing's sarcoma. So this is one again slide just telling you, like, for Codman's triangle, you should not take it for granted that it is present in osteosarcoma only. So this is the Codman's triangle here. So Codman's triangle should not be taken only for osteosarcoma. It can be seen in Ewing sarcoma, even osteomyelitis, or there are, you can see plenty of conditions, right? So as far as this question is concerned, the answer is Ewing's sarcoma. Okay, chalo. next move forward to the next question, and this was about the nerve supply of the area marked, right? So this all area is the territory of the auricular branch of vagus nerve, right? So this is the territory of the auricular branch of vagus nerve. Clear? So if we take the image something like this is all territory of the auricular branch of vagus nerve. Okay, so this is the auricular branch of vagus nerve. Now lower down, this is all great auricular nerve, and upper side this is auriculotemporal nerve, which is coming from mandibular division cranial nerve 5. Okay, so this is how you can remember. This is all auriculotemporal, and lower down is great auricular nerve. Okay, so please remember like this. So this is in fact auricular branch of vagus nerve. Okay, now there was one question about Samter's triad, and it was asked like which is not a component of Samter's triad. So we know that in Samter's triad there is bronchial asthma, right? There are nasal polyps, and there is sensitivity to NSAIDs, especially aspirin, right? So these are the components of the Samter's triad, and here the thing is that it is actually sensitivity to a group rather than to a drug alone. So this is actually spatially, right? So if someone says that it is sensitivity to aspirin alone, that is a false statement. It is to its group member or even to any NSAID which is inhibiting the cyclooxygenase 1 enzyme, right? So the answer is this. Now there was one question, and in which implant was shown, right? So this is the AP view and this is the lateral view here. So we can see an implant which has been inserted through the intertrochanteric area and through the neck of femur, and finally we can see this threaded part here, right? So this is the dynamic hip screw, right? So this is known as DHS, and here we have 3 components to this. There is a plate, there is a cannulated screw, and then a locking screws. We can put the screw something like this here, right? So something like this. So this is the dynamic hip screw, and whenever we use the word dynamic, it means there is some movement, right? So this movement occurs between this area, right? So there is a hole something like this, right? And this cannulated screw is actually past something like this. Okay, it is something like this, and then it is fixed with a screw here. So this screw can move something like this. So this is the concept of dynamicity here. So this is dynamic hip screw, and this is indicated in intertrochanteric fracture. Clear? So intertrochanteric fracture, right? So if I show you the intertrochanteric fracture, it will be somewhere like this, going from the greater trochanter to the lesser trochanter. So this is the intertrochanteric fracture, right? So this is the fracture intertrochanter. So for this we do the dynamic hip screw. Then a next question: a singer was unable to sing on high notes, and when we do a laryngoscopic examination, we saw that the vocal cords was slightly bowed, right? So we can see the bowing of the vocal cord, and it means whenever we say there is bowing, so bowing of vocal cord, it means it is not tensed, right? So it means the muscle which is responsible for tensioning is not working properly, right? So the tensor muscle is not working properly, and the tensor muscle for vocal cord is cricothyroid, right? So it means the muscle affected in this condition is cricothyroid, and we know that cricothyroid is supplied by the external laryngeal nerve, and we also know that all muscles of larynx are supplied by recurrent laryngeal nerve, and there is only one exception, and that exception is the cricothyroid, which is the tensor of the vocal cord, and this tensor or this tense action is needed for producing high notes, right? So if someone is not able to produce high notes, it means the tensor muscle, that is the cricothyroid, is not working properly, right? So if you see this kind of laryngoscopic image in which the vocal cord is bent or bowed or depressed, and if it is not tensed, it means there is some problem with the cricothyroid muscle. Okay, so this is the summary of this question, right? Then there was an X-ray, and based on this, students were supposed to make a clinical diagnosis. Now here you will notice 2-3 things. Number one, look, this is the aortic knuckle, right? This is the aortic knuckle. Then look, this is the heart border, and this is the apex, right? So second, we can see the apex. So this is the left sided apex, if right. So we can, this is left sided apex, right? And aortic knuckle is also right sided, I'm sorry, left sided is normal actually, right? So this is extremely sorry. So right sided apex and right sided aortic knuckle. Now both these structures are normally on the left side, but here they are on the right side. Then what we can see lower down, we can see the fundus, here in the fundus of stomach, right? Now this is also on the right side. Normally this has to be on the left side, so this is also on the right side, right? So what does this mean? This means there is situs inversus. Okay, so there is situs inversus. It means the organs have changed their side. Clear? So the left sided structures, left sided has now moved to the right side, and that is what is shown in the X-ray. We can see that the aortic knuckle is on the right side, we can see the apex of the heart is on the right side, we can see the fundus ear shadow is also on the right side, right? So this is one thing which we can see in the X-ray, situs inversus. Now secondly, what we can see certain rounded shadows, right? So this is more suggestive of bronchiectasis. Okay, so this is suggesting bronchiectasis. Okay, so this is number 2, that is bronchiectasis. And in this patient there might be sinusitis as well, and this all will go in the favor of Kartagener syndrome, right? So this is what a patient of Kartagener syndrome will present with. There will be situs inversus, the organs will change their side, there will be bronchiectasis, and there will be sinusitis. So this is a classical, X-ray for Kartagener syndrome. Okay. So this is what we will see in Kartagener syndrome. We will see dextrocardia. Yes, this is right-sided heart. This is dextrocardia. Yes, of course. So this is dextrocardia, right? Dextro means right, cardia means heart. So the heart has gone on to the right side. So we can see dextrocardia here. Okay. Then we can see the right. This is aortic knuckle. Okay. So this is the aortic knuckle, that is right-sided aortic arch. Then we can see the fundus shadow on the right side, and then we can see small bronchiectasis changes here. So this is all bronchiectasis, classical X-ray. And then if we take CT scan, then it is the bronchiectasis changes are quite obvious. We can see these rounded, right? So these are all classically seen on high resolution CT scan, right? So this is all bronchiectasis changes. And sometimes what we see, we will see signet ring appearance, right? So we can see signet ring appearance, or we can see tram track appearance. These are all features of bronchiectasis. Okay. So classical case of Kartagener syndrome. Ajimsha Shaukat, today I'm focusing only on ENT and orthopedics. Yes, I'll take subjects in sequence, and definitely I'll take psychiatry as well, right? So maybe tomorrow I'll take psychiatry or dermatology or some more minor subject. So I'll go in a systematic manner so that we don't miss any question for that subject specifically, right? So today I'm just focusing on this ortho and ENT, right? Chalo, next question. And it was about the duration of time for which a cast is applied in fractures of fifth metatarsal, right? So we know that for fractures of fifth metatarsal, we can just do a conservative method by below knee cast. Okay. And this is usually applied for nearly, you can say, 2 months. So 2 months time is sufficient for the fracture to unite. Now when we discuss about fractures of fifth metatarsal, you need to remember two fractures in relation to that, right? So because at the base of fifth metatarsal there is attachment of muscle tendon, right? So this is the tendon of peroneus brevis, which is going and which is inserting onto the tuberosity of the fifth metatarsal, right? So sometimes what happens when this muscle tendon contracts vigorously, it can pull off a chip of the bone with itself, and that is known as avulsion fracture, right? So sometimes we can have avulsion fracture base of fifth metatarsal, and this can be because of strong pull by peroneus brevis muscle. Okay, so this is one possibility. And then second is of course the Jones fracture, which we discuss very oftenly, that is the fracture of the base of fifth metatarsal, right? So this is the area of Jones fracture, and this is the area of that avulsion fracture, right? So this is the area of avulsion fracture, and this is the tendon of the peroneus brevis muscle, which at times can take away that chip of bone, right? So two injuries in relation to fifth metatarsal. One is Jones fracture and second is the avulsion fracture. Okay. Then there was a X-ray of the chest, and there was a foreign body in the esophagus, and it was asked like what sign you can see on the given chest X-ray. Now here, if you look properly, you can see, if suppose this is an outer ring, and then you can see inner ring, something like this. Okay, so the presentation is something like this, right? So if you see, this is the margin of one ring and this is the margin of other ring, right? And this is all something like this. So this is classically known as the double ring sign. Okay, so this is known as the double ring sign, and that is a battery button actually, which has been ingested by the patient, usually a child, accidentally, right? So this is known as the double ring sign, and this is one way to differentiate this from a coin, right? So this is actually a button battery double ring sign, right? And when we look at a coin is fully homogeneous, just one kind of density all around. But in a case of button battery, we will see a classical double ring sign. So you can see a black line somewhere like this. So there is a black line which is there between the two opacities, right? So this is the double ring sign of button battery accidental ingestion. So this is enough for today's session, and I'll come back again tomorrow with many more questions from minor subjects especially, and I'll try to include the questions from both the sessions, right? So thanks for giving me your valuable time, and we'll come back tomorrow, right? So it's good night from my side. See you tomorrow. Bye bye. Shanawaz bhai, you are slightly late, I guess, but no problem. You can just review the video, and I'll expect you to come tomorrow right on time, right? So see you tomorrow. Good night.